We now have the pleasure of welcoming Dr. Jackie Chua, who is a specialist obstetric gynecological ultrasonologist. Did I get it right? Yes. Yay. We've been training that for a couple of years. And the director at Queensland Ultrasound for Women. This is big. I really am excited to share and break down with you what is the ultrasound for endo, how has it shifted, how has it changed, because it's not just the Joe Blow down the road that can do this type of endo pelvic pain ultrasound, and just a fabulous service that you are sharing and training and offering. So please welcome Jackie.
Alrighty. And it's just that one, isn't it? Yeah. Excellent. Jess did a fantastic job. I sent this PowerPoint presentation to Jess about, she said, latest Friday, 3 p.m. I said, I'm pretty sure she meant Thursday. So she got it. And so let's see how this goes. Thank you for inviting me tonight. I'm going to take you through a whirlwind in regards to ultrasound and endometriosis. Why do we actually use an ultrasound? It's the integral part of a gynecological assessment for both benign and malignant diseases. It's because of the fact that it's easily accessible. There's pretty much a radiologist on every corner, isn't there? It's considered minimally invasive. It's safe. It's a cost-effective imaging modality, and it provides real-time visualization. Now, the quality and accuracy, though, can be affected by many different factors. And the first one is actually the ultrasound machine that we use. I use a GE machine, which is worth a few bob. All right. And with actually the highest end, actually transvaginal probes I can get. And it's also the operator, the person who's actually, and I said this to, I think it was Jill last time. I said, oh no, it was actually Kathy. I said, I'm a wand waver. I have a wand, and how do I use it? My sonographers are very well trained in regards to what they have to do. That comes with me in regards to being the reporter. I'm the one who actually translates and actually try to decipher all those shades of gray in front of us to put it onto a report so that everyone else can actually understand what is going on inside. And the patient also gives us a little bit of limitations as well. Transabdominal scanning is very limiting in regards to how much I can tell you what's going on inside the pelvis. Transvaginal is gold standard. The patient's body habitus does work against us, and therefore it decreases the penetration for me. There is basic or standard, I guess, ultrasound scans, and there's advanced. This basic or standard one is what you get in a 20-minute gynae scan when you're going to any provider, basically. It just looks at the uterus, the ovaries, the cervix, the fallopian tubes indirectly, and the pouch of Douglas. That's a normal standard ultrasound scan. However, the advanced ultrasound scan is actually what we do. What do we do beyond that? We're looking at the uterosacral ligaments, the anterior compartment, which comprises of the urethra, ureter, and the bladder, the posterior compartment, which is the rectovaginal septum and the rectosigmoid bowel. And we're not just going to go picture click, picture click, picture click. We are actually assessing it dynamically. All right. We assess how well does that uterus move? How well does the ignexe move as well? So going on to adenomyosis, it was considered previously a histological diagnosis. You got the uterus from the surgical specimen and you found out what it was on histo. We can now try to give you a diagnosis before you actually have to go to surgery. All right. Transvaginal, as I said, is the best way of doing that. On histology, what we're seeing is because we've got endometrial glands and stroma, the muscular hypertrophy, the increased vascularity, and there's a disruption of what we call the junctional zone. The junctional zone is actually the interface between the endometrium and the myometrium. And it's that area there that we think there's the breach that has occurred of those glands going from one area to the other. We don't know, as we have said already, we don't know what the pathogenesis is, but it's one of the theories there. And what we see on ultrasound is actually the result of all of these things. And so we've got different type of groups that go around. You got Europe, you got America. Oops, sorry. We don't actually have a group per se in Australia because we do take from a lot of different areas. And I think we picked the best of what we've got. But the MUSA group is one of the groups that came together and said, let's standardize this approach of how we look at the patient by the approach and also the nomenclature that we are using so that we are all speaking the same language. Adenomyosis is divvied up into 3 different types of groups: diffuse, focal, and adenomyomas, or adenomas. And we use these type of, sorry. Okay, my apologies. I assumed they were going to work. All right. So we use all of these features to try to give you that definition. They have recently divvied it up, actually, divided into direct and indirect signs. The direct signs are those, what we call the myometrial cysts, hyperechogenic islands, and these things called the subendometrial lines and buds. The indirect one is kind of saying it's a globular uterus, and that's one of the things that you will see on actual reports. And I would say to you, I don't really know what the definition is because they don't have one. They used to say if it was a uterine volume of 100 mils or more, you can call that globular. It is actually a very subjective opinion as to whether or not you call it globular or not. Fan-shaped shadowing was one of the things that they looked at, and interruption of that junctional zone, as I spoke about previously. The best way to look at the junctional zone is not through normal 2D imaging, but it's actually through 3D imaging, looking at what we call the coronal plane. So what I tell my patients is that your uterus, what I'm going to do is actually cut you in half like a sandwich and open you up, and I'm going to look at the junction between your uterus and your actual endometrium, which normally comes off every month for a period. Excuse me. So, okay, sorry. There we go. Oh, sorry, these are supposed to start. What you may or may not be able to see so well there is actually these little black little dots. They're the myometrial cysts that we're looking for. And with a bit of eye of faith, as we scan through the uterus, you'll actually see these kind of black light lines. And that's actually what I called it the dappled sunlight effect, because it reminded me of actually how the sunlight comes through the Venetian blinds, which is what they call it. But it's the different interfaces inside the myometrium as the ultrasound hits them and how it gets reflected back to the ultrasound machine. It's quite a nice look when you got it there. The accuracy of ultrasound for adenomyosis is actually about almost up to 80% on transvaginal scanning. So like I said, it can be diagnostic. The 3D imaging will increase that sensitivity up to about 90%. The best markers for us to look for on scan is the subendothelial lines, the myometrial cysts, and the asymmetrical myometrial thickening. However, it's very operator dependent, and the pickup rates are actually better if you actually ask the clinician, I think there may be adenomyosis, can you please look for it? However, if you are just saying they're there for a fertility workup or there's a cyst seen or something like that, and if they're not thinking about it, then they will miss the adeno that's sitting in front of them, okay? Endometriosis, all right. We know what it's causing. It's causing a chronic inflammatory processes that leads to neovascularization and fibrosis. That then leads to adhesions, and depending on where those glands are sitting, you're causing alteration to the pelvic anatomy. So we are very good at looking at the pelvic region, but I'm not going to pick up that diaphragmatic endo at all. I have a sono who's trying to teach me how to do it, and I'm just going, sorry, anything above the belly button, not for me, sorry. I'm a gynecologist, not my area. So the problem, we all know what the problem is the delay in diagnosis because of the fact that it causes the disease sometimes to worsen, but also the economic and obviously the psychological impact associated with it. The problem we have on ultrasound is that the symptoms don't always correlate with the severity of the disease. So you can have really bad endometriosis on scan, and you're going to say to me, oh, I got a little bit of pain with my periods, but not much. Whereas conversely, I'll have some ladies who have horrible in regards to dysmenorrhea, dyspareunia, and all the disses, and I will see very little in regards to actually endometriosis on scan. So it does not have to correlate. We're unable to predict their fertility status. So I do a lot of tubal patency exams in ladies who have got endometriosis to try to see whether or not it has or has not affected them in that respects. Surgery, as we've already said, is not always the answer. I do say to patients, if I find it difficult upon insertion of the transvaginal probe to get past that pelvic floor, and as soon as I've passed it, if actually they are fine, I say, you need to go see a pelvic floor physio. And then I will tell them to do that. And then hopefully they will do that with their GP in conjunction. The most common site in regards to the extrapelvic is going to be the GIT tract. So there are three types of endometriosis we can find, or three types of endometriosis: the superficial, the ovarian, or the endometriomas, and the DIE or the DE, the deep infiltrating type. We don't have a reliable ultrasound staging technique or system. It's still considered surgical. There's lots of different, research papers into it, but we are unable to give you a severity of the disease that's going to be helpful consistently. A normal physical examination by a GP does not mean that an ultrasound scan should not be ordered. It should definitely be ordered, okay? And on my side, a negative or a normal ultrasound scan will not exclude endometriosis. And so the other group that was involved in regards to this, the nomenclature and trying to standardize the approach to endometriosis was the IDEA group. And they said transvaginal scan first line. The accuracy is very dependent on the operator and their experience. And what their aim was with the idea was to explain the symptoms, to try to help map the disease location, and try to help assess the severity of the disease and plan, therefore, appropriate care. So there's 4 steps that we do on scan. The first one is do a routine scan, okay? And obviously in transvaginal, except if they're Virgo intactum. And we're looking at the uterus in all the planes, and we're looking at the ovaries, and we're also assessing the myometrium for adenomyosis, and we're looking at the ovaries to see if there's any endometriomas. Endometriomas should be very easy to pick up on ultrasound scan, and that should be in approximately about 90% of the time. They are very well circumscribed. They've got a very thick wall. They're avascular, tend to be unilocular, but you can get some multilocular ones. And they have a homogeneous or low-level echoes internally. All right, they've got a very typical appearance. It's called ground glass appearance on scan. And some of them can look a little bit atypical, and we sit there going, oh, is that an endo? And that's because of the fact that they might have these little kind of hyperechogenic walls or foci, or sort of little scattered little areas there inside the walls. And it just makes us question a little bit, but majority of the time we should be able to go, that's endometriosis, and that's an endometrioma. The other thing we shouldn't forget is the poor little fallopian tube. They're just hanging about there next to the ovaries, next to the uterus. Because of the fact that if they're not diseased, we're not going to be able to see them on scan because there's nothing to see on scan. They don't have a lot of volume. But if they are actually compromised, then the most common thing I'm going to see is going to be a hydrosalpinx, which is a damaged tube that's swollen. It's got a very typical look to it there. You can see it on 3D imaging. And also, if it's involved with actually the ovary as well, then the whole thing, the ovary and the tube, will move en masse. The second step, so that was just the first step, all right? The second step is actually looking for what we call sonographic soft markers or site-specific tenderness. So how well does that ovary move? Is it fixed? So what we do is, this is a normal ovary sitting there. We are palpating it from down below and above through the tummy, and we're seeing how well does it actually move against the uterus and also the pelvic side wall. And we're comparing that to what we might find. So this is to show you here, that's the ovary, that's the uterus. And you'll just see it's moving a bit, but it's just slightly restricted in comparison to the first image that I showed you. Whereas here, if I told you that's an ovary and that's an ovary, and this is the uterus in between, and this is on transverse section, I've got a uterus here, and I've got actually 2 ovaries that are sitting here, and I'm pushing on them, and they're not moving. They're in what we call the classical kissing position, where they're adherent to the posterior wall of the uterus. Once I see that, the first thing I'm going to do is I'm looking for bowel endo. That is what triggers me to actually look for more things. The third step is considered the sliding sign. I must admit, when they first published the paper, they said, see if the sliding sign is positive or negative. And I don't know why. I'm a very simple person. I don't understand what positive means and what negative means. So I prefer to say, is the sliding sign present or not? And what we're looking for is the bowel movement now. And on scan, a normal sliding scan, there's you see, oops, sorry, it's a bit short that, but there's the uterus, and you're seeing how well it moves against its actual surroundings. Whereas this is the uterus here, and you can see it's very restrictive in regards to its movement. It's also stuck to an endometrioma as well, but that is another sign that we're looking for. The obliteration of the pouch of Douglas, so the pouch of Douglas between the uterus and the actual rectum. If I see a very fixed or retroverted uterus, then I'm going to say, where's the endo? And it's got this classical kind of question mark sign. If you see there, this is the cervix, this is the uterine cavity, and it's coming down, it's just dipping down. And if I were to move that, it's not going to move and flex out. This is just showing you here, another sign here. This uterus I'm trying to open it up to see if I can get the cervix off of the back of the uterus. And you can see that it's actually just sitting there bobbing away, and it's not opening up like it should if it wasn't actually tacked together. So that's another obvious sign that I will pass on to my colleagues to tell them there's obliteration of the POD or the pouch of Douglas. The fourth step is the extension from the norm. And that's when we're looking at the anterior and posterior compartments. The anterior compartment, as I said, was the bladder and the uterus and the uterovesical region. The anterior compartment, normally, this is the bladder here. This is the anterior part of the uterus. And with an eye of faith, you can see that that bladder is able to kind of shimmy off of the actual front part of that uterus. Whereas over here, there's something obstructing my ability to do that. There's a mass right there in the bladder wall. And this lady's got an anterior compartment endometriotic nodule. The posterior compartment is the more common area we're going to find actually bowel endo or endometriosis in general. Like I said, I'm a gynecologist before I actually went into imaging. And so some of the words that my radiology colleagues actually use, I have no idea where you are in space in that because I never called certain things that way when I was operating. But the uterosacral ligaments is basically the two supporting ligaments to the uterus. And that's one of the most common areas that we'll find endometriosis. On scan, it's this little kind of whitish line here. And it's just behind the posterior fornix of the cervix at the top of the vagina. And I'm aiming my probe to look at that area there. That's just slightly thickened, but there's no obvious nodule. Whereas here, you can see there's a disruption of that actual hypoechoic area with this little lumpy area here. That is your endometriotic nodule in your uterosacral ligament. So here is actually a loop of bowel, single loop of bowel. It's a bit thickened on its wall, and it's actually moving. As I move the uterus, that loop of bowel moves with it. And so there's another area of endometriosis. We also need to ascertain not only the number, the distance of the actual nodule is from the anal verge, the depth of invasion. So how far has it gone through the bowel itself? So if I say it's gone past the muscularis, that means Albert's going to go get a colorectal surgeon to come in with him on that surgery. And how many loops of bowels, if we can actually figure that one out, are involved? These are just some of the images we've got. Oops, sorry, apologies. Just showing you the bowel wall, single loop bowel wall nodules. They can look quite impressive on scan. Superficial endometriosis is the hardest thing we can see on ultrasound, unfortunately, and we have just started to try to shift our focus towards that. And so we've got a lot of different possible signs, but these lesions are super, super small. So on ultrasound, they're not easy to see. So we do it by inference, again, by mobility. And what are we seeing is these little echogenic kind of scattered little foci that are actually on top of the surface area of the ovary itself. But mobility is actually the best marker for us for superficial endo. Adhesions, we can see them. We don't know if we can actually differentiate them from actual endometriosis versus actually post-surgical adhesion formation. But the accuracy of ultrasound is diagnostic for endometriosis. It's not saying, oh, I think you got endo, go have surgery, see if you can prove me right. I'm actually saying, hey, Albert, there's actually endometriosis here, here, and here. Where do we do with this lady from here? So like I said, a negative scan does not exclude the possibility of disease. He also, Albert did touch on the malignant transformation in regards to endometriosis, and we can also look for those things in the older age group as well. The RANSCOG guidelines, living evidence guidelines, was published back 25, I think it was. And they have quite a few recommendations. And the first thing is obviously go to an operator that knows how to do deep endo scanning. And one of the things we have in regards to Medicare item numbers, one was the MRI for the pelvis for subfertility and deep endo. This has to be requested by a specialist or a consultant physician. You can only ask for it once every 2 years. And you have to specify on the referral that you suspect deep endo. The normal Medicare item number, which is used for the gynae ultrasound scan, is 55065. It has a rebate of $112. I spend at least 30 to 45 minutes scanning these ladies. If I'm actually on site at that location, I will go in and tell the lady what she has, and I will explain what it means to her. And that doesn't happen to everybody. But this particular item number is actually shared between us and the boys. This is actually for all genders. However, we use it probably about 99% of the time. It was probably billed in the 25 financial year, $150 million. All right, so it's significant. However, back in November of last year, but we knew about it because I was on a webinar with Jess, and she got this phone call just at the end of actually our webinar saying the government had just approved this new item code number for us, which is actually the 55080. What we didn't know was actually the stipulations that were going to be attached to that from Medicare. So the Medicare rebate now is significantly higher, and it's much more reflective of the time and expertise that we put in to scanning these ladies for $255. The couple of things that are a little bit hard to kind of, I guess, reach for Medicare is one, on the referral, it must say that the clinician, the GP, or whoever's sending this person for a scan has to have a degree of suspicion that they might have endometriosis. So you have to put that down on the referral or put down pelvic pain. If you do not put that down, I cannot actually apply this Medicare rebate, all right, which is significant for your patients. The other thing that they've also said is that we need to scan for 30 minutes. Now, I know those who've had a transvaginal scan done would not want to have that for 30 minutes. All right. So we've had to do a bit of tweaking on that to see how we can meet the Medicare criteria. But it's a significant change to what we were getting. The other notes in regards to what, like I said, you have to have a degree of suspicion for endo, for adeno. I don't do pelvic congestion syndrome. That is actually a Doppler type of investigation. Like I said, that's a radiology thing. Chronic PID or pelvic floor dysfunction. I don't do pelvic floor scanning. I send that to my actually urogynecology or actually physio friends to do. But like I said, you must put it down on the scan referral that's your degree of suspicion. So all I want you to do is take home from me tonight is saying that not all scans are created equal. That transvaginal scanning allows us to do the best assessment we can for your patients to try to give you as much information as we can. An extended gynecology endometriosis scan actually only adds about 5 to 7 minutes to a scan for us in regards to what we do. But we do an extended scan on every patient who walks through the door. We don't do a standard scan, except for the Virgo intactus. It's all going to be on TA or transabdominal. And for my 80-year-olds and above, okay, I'm not going to do a full gynae scan on you. But experience definitely does matter. All right. And don't forget in regards to that Medicare rebate, I'm just going to harp on that one more time. Put down endometriosis assessment or pelvic pain. Okay. And thank you very much.
Really?